Hey everyone, welcome back to the EMS Academy. For those who haven't met, my name is Sean Barinholtz. I am an anesthesia and an ICU physician at Hopkins. I'm an active member of Pikesville Volunteer Fire Company in Baltimore County, and I have the honor of serving as one of the assistant medical directors for Baltimore County Fire Department. On behalf of Dr. Jeff Nussbaum and the medical director's office, Chief Nats, EMS office, EMS Training Academy staff, and Captain Lenny Stewart, thank you for what you guys do to help our community every day. And thank you for your dedication to lifelong learning. Big shout out to Ashley Brooks, a young member of Pikesville, who's helping us run our Zoom platform. Ashley will also, towards the latter part of this training, send out a link in the chat. Keep an eye out on that. We'll also announce it. Enter some information to get your MIM CEUs. If you have any challenges with the information, filling out the form, questions about past participation, anything related to CMEs, please hang out with us after the training and make sure that we have our questions answered. We're unable to go back after the training to try to resolve challenges with signing in. I'm so sorry. So please feel free to hang out afterwards if you have any questions about your MIM CEUs. Super happy to be back. Super happy to have with us starting off this season, Dr. Rodney Omron. Dr. Omron earned his medical degree and MPH in epidemiology from George Washington University School of Medicine in 2000. He completed a residency in emergency medicine in 2008, and then worked at the University of Michigan as a clinical teacher and ultrasound site director. He came to Hopkins as assistant program director in 2010, was quickly promoted to associate program director. He was the former simulation director, evidence-based medicine director, and ultrasound faculty for the Department of Emergency Medicine. Dr. Omron has taught nationally on deliberate practice and the clinical diagnosis of dizziness. He is currently co-leader for the education core for the Center for Diagnostic Excellence at the Johns Hopkins Armstrong Institute. On a more personal note, he's a loving father of Emmett, Nora, and Gillian, who is a super talented cello player. He is a husband to Kate and is active in the Boy Scouts of America Troop 742. Dr. Omron, thanks for being with us. Thanks for sharing your wisdom and passion for this topic.
So it's my honor to be here. I really appreciate the invitation. It gives me an opportunity to kind of share with the group something I'm very passionate about. And I want to take this hour to give you guys the opportunity to take advantage of my area and also my time to be able to answer any questions you have. I've created a slide set, but the slide set is just for talking points. I have cases that I've seen, I have cases that my partners have seen that I have on the slide set. So I'm going to share my screen and I'm going to start, but feel free to, number one, put the questions in the chat or ask, and I'm happy in the middle of anything to stop and we can direct the conversation in any way that you think would be beneficial to everybody here. So let me take 1 second to share my screen here and go to my PowerPoint. And then from there, we can begin. Here we go. So this is kind of the overview of how I have structured this discussion. I'm going to take a few minutes to talk about the pathophysiology because, as Dr. Newman-Toker says, the beauty of this disease is that the imagery catches up to the pathophysiology. And before you actually see it on MRI or CAT scan, you see the actual physical findings that it's doing to the body. And then afterwards, I'm going to spend some time talking about what you have in the history and the physical to help to guide you when you're trying to decide whether or not this patient is having a stroke or having a benign condition. And then I'm going to give you examples that I have collected as well as my partners have collected. And we'll talk about paramedic-specific diagnoses and the evidence that's out there. So as I said, my objectives, as I described. Now, this is the crux of the entire talk. This is why, as I was saying earlier, it's really hard to make this diagnosis. Number one, this is different than how it is when this patient arrives in my emergency department. When a dizzy patient arrives in my emergency department, it's a situation where it's a low risk, high frequency because I see so many dizzy patients. But the number of dizzy patients that you see are only 5% of your missions. And in addition to that, only 5% of those patients are time critical conditions, which are strokes. And so as a result of that, you need to come up with a framework that you can use that can help guide you and help to support you in your decision making, so that when you so infrequently see one of these patients, you are able to come up with a reliable decision every time. So does anybody have any questions about this? So this slide is meant to make you feel dizzy for a second. And these are the different things that people say. They say, I feel like being on a carousel. I feel off balance. I feel like I am about to faint. I sometimes feel like the motion of the sea, as though I'm on a boat. And as a consequence, it's really hard to bucket these patients. Is this cardiac? Is this a stroke? Where do I send these patients? Do I automatically just make the decision to send all these patients to a stroke center? Can I somehow have an idea of whether or not they're higher risk or if they're not? And this is from that prior paper. As you'll see, the majority of these patients are either peripheral nerve here, which is a mixture of benign vertigo, inflammation in the inner ear, which is called vestibular neuritis, a bacterial infection, which is called bacterial labyrinthitis or zoster. And then mixed with that are all these people over here, which are upper respiratory tract infections and hypertension and bradycardia with AV block and sepsis and coronary artery syndrome. And then this is the dreaded area right here, which is your stroke and your transient ischemic attack and your tumors and your multiple sclerosis. And that is such an uncommon finding. Between that and coronary artery syndrome, the diseases that we need immediate attention, these are far fewer, maybe even at the realm of 3 or 4% of the entire population. This is the crux of my talk. This is the slide that has it all on there. What is so beautiful about the vestibular system is that it allows us to maintain balance. And the way it does it is so fascinating. It has these little tiny rocks called otoliths. And in the otoliths is this membranous gel that slides back and forth. And as the fluid shifts, these otoliths move, and it allows the position to be detected by the brain with these little follicles here. So when you bend forward, all the otoliths get pulled down, and that tells the brain the direction of the gravity and where the gravity is pulling. And it just doesn't do it in one plane. It does it in 3 planes. It does it in a anterior plane, which is the anterior canal. It does it in the posterior canal here, and it does it in the horizontal canal here, so that we can have 3-dimensional decisions of like where we are in the world spatially. Furthermore, it also has another side. So there's one on each side of you, and so you can determine sidedness. So if one side is being stimulated, the other side is being inhibited. So the right side is being stimulated because I'm turning it. It's going to tell me I'm turning right because the left side is being inhibited. So I could do that with my eyes closed and still know I'm turning right. In addition, this is one of the foundations of why we can have what they call benign vertigo, which is not benign, because benign vertigo can cause disability, it can cause falls. It's a high risk situation for somebody who's in their 80s, who, because of their benign positional vertigo, falls and breaks their hip. So it is a misnomer that benign, and it also results in lost time at work. So benign positional vertigo is something that is easily treated and diagnosed with a little bit of knowledge of the underlying disease process. So I did a cool thing here. I wanted to show you, when you have the anterior canal, you can have a little particle. There's a little particle. Can everyone see that? That's a little particle in the anterior canal that slides up and down and up and down. And that's one of those little tiny little pieces of the otolith, the little tiny stones that for some reason, maybe they had trauma, maybe they have vitamin D deficiency, some reason caused that little tiny otolith to dislodge from this wonderful collection here and is floating freely in this canal. Similarly, you can have one in the posterior canal, and you can have one in the horizontal canal. Now, as a consequence to this, it results in different types of vertigo because your ear is sensing movement in a different plane. And lastly, you can have inflammation in the horizontal canal, which is called acute vestibular neuritis. And that's an infection of some kind. Maybe it's a viral infection. And that can be triggered where that entire canal is so inflamed that there isn't a little particle in there, but because it's being triggered, the brain recognizes it as one side is being continuously stimulated. And that's called acute vestibular neuritis. And then furthermore, parts of this entire apparatus could die. And that is a stroke. So there are two different types of circulation that affect this entire apparatus, and that is the pica and the ica. So the posterior inferior cerebellar artery and the anterior inferior cerebellar artery have the opportunity to both circulate into here, and they do it through these tiny little labyrinthine arteries. So when one of these arteries are occluded, it is not completely out of ordinary that the MRI is negative because it's such a tiny little artery that you can't see the little occlusion in that artery, but you can only see the cell death and the result of the destruction that appears days later, which is why oftentimes these strokes are silent on the initial MRI if people are coming in very quickly. And with that being said, we have the opportunity to be able to diagnose different types of vertigo based on where in the canals they are, because they behave differently. So we'll go to posterior canal first. But before I do that, I just want to take a moment to see, is there anything that I can answer about what I'm talking about right now? And then I'm going to give some examples of posterior canal type vertigo and horizontal canal type vertigo.
Not seeing anything in the chat yet.
Love it. All right, well, off we go. I'm excited to do this because I've made it so it's a hyperlink here. There we go. And then there we go. So this is the a video from one of my colleagues, Dan Gold. Let me see before I do that. I'm going to try to move this off the screen. There we go. And what I just want to show you, I'm not going to show you this whole video because I'd like to talk instead, but where I'd like to show you is that. So what that is, when they drop the head like that, and you see that upbeat rotary nystagmus, that's because it stimulated the right side posterior canal. So I'm going to show that one more time. So that's the head dropping, and then this is the eye being stimulated, and that's called upbeat torsional nystagmus. And you can see it's upbeat and it's torsional, which is telltale. And this only occurs when you perform this maneuver called a Dix-Hallpike. Otherwise, there should be none of this nystagmus at rest. So this is a type of vertigo where the posterior canal is involved. And
can you describe the torsional component?
Sure.
I think we can see the vertical. Yeah. It's
the twisting here. If you, let's go back and I could do it one more time. You see how it's going broom, 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 broom. Does everybody see that? Yeah. Do it one more time. So you'll see the difference because I have an example of one which just is strictly upbeat. So it's this turning component too. And the turning component is to the right ear, which is why I know that this is right benign posterior canal vertigo. I'm going to do it one more time just for the sake of clarity here. That's the best at the beginning. These types of vertigo fatigue over time because your brain gets used to it. So you'll be surprised that your colleague is able to elicit this, and then you try it again and you're not able to elicit it. So yeah, so the up part is going up, and the twisting part is the part you see. Now, this is a maneuver that we use to fix it. It's called an Epley maneuver.
To treat the right posterior canal variant.
And I am going to just show you the Epley maneuver really quick. So basically what the Epley maneuver does is it takes that little tiny particle that's in the right ear that's sitting there, and it rolls it out. So it rolls it out so it goes back home, back to where the otolith lives. And that temporarily fixes it. So what we do is we recommend to the patients that they need to follow up with vestibular therapy because it has a good chance of reoccurring, because it doesn't actually cure the underlying disease process, which are these little flecks that are falling off your otolith. All it does is it treats the immediate symptoms and makes you feel immediately better. And that's all that maneuver does. And then they should follow up. And also, I send them home with this video, and they can do this at home for themselves whenever they have it. So they don't have to come into the hospital. So that is what they call benign positional vertigo. And this is the posterior canal type. That was the first type. I did not include anterior canal because, number one, it's rare. So I always want to just assume that if you see that type of nystagmus or that type of, you would just bucket it with the strokes just in case, because I don't want to ever be in a situation where we miss a stroke and we call it benign vertigo and send them home when they're really having a stroke. And the other part about it is most of the time, because it's upwards and downwards, if by standing, most of these actually resolve just by being in an upright position. Next is horizontal canal type. So horizontal canal type means it beats left and right. And I'm going to show you that too. This is what's called a soup. And if you look here, this is a very, very, very slow beating on the right. And then what you'll see is when he does the roll on the left, which is the affected side, it's going to get super strong. So that's the affected side is much stronger, and they feel it. There we go. So that is a left-sided horizontal canal type vertigo, and it's stronger to the left, and it's beating towards the table. That's what's happening there. This is treated by rolling the patient along the bed, which is called a barbecue roll, and all you do is roll them around. You start with them in the lying down position, and you maintain all of these movements for 30 seconds until the symptoms completely resolve. And then you move to the next position, and then you move to the next position. And all you're doing is similar to the other one. You're just taking the opportunity to take that part and roll it back to where its home is. And this works amazing. One time I had a man who came from Florida that was in hospice, and Justin, the tech that does all the video oculography stuff, and I saw him together, and I immediately realized that this man doesn't have end stage disease. He has horizontal canal BPPV, and they came from Florida to my ED because they were at their wits' end. They didn't know what to do, and within 15 minutes he was cured. And it was the most gratifying thing in the world. That is one reason why it's fun to learn these techniques, because you do feel a little bit like a wizard, because you're able to do something in medicine that is so infrequent, where you see a disease, you have a treatment, you do the treatment, and the patient has immediate relief. And if you didn't do the treatment, most people wouldn't know how to do that. And then lastly, we can have that inflammation I was telling you in the canal. That's called acute vestibular neuritis. And I want to see if I can go to this YouTube video, Peter Johns, because this is more complicated. And I actually think that sometimes this is even hard for emergency physicians to do.
Southern Oregon.
So I have to wait until Harry and David. There we go.
While we have Harry and David,
Okay.
there is a question. Do these maneuvers ever result in emesis?
Who to perform the HINTS exam on, how to perform it, and how to interpret the findings.
So this is the way.
The HINTS exam is used when a patient presents with many hours or days of ongoing continuous vertigo, nausea, and/or vomiting, some difficulty walking. Their vertigo gets worse when they change position, such as going from lying to standing, and importantly, you can observe spontaneous nystagmus. Diagnose vestibular head impulse test.
All right. So these are the three components. We're going to go through each
Nystagmus.
one. You have
observe in
normal-
primary gaze where
It's
the
normal to have
finger is on the
nystagmus.
finger if you put it there, or something.
And let me see if I can actually go and show that. This person has nystagmus that's one direction. That means that he has beating that is going towards the left. And this is at rest. This isn't in any way stimulated by a movement. He's just sitting there.
When he looks to the left, his nystagmus increases.
And that's great.
towards the
That's
left.
actually
The last
reassuring.
component to the right.
This is not reassuring if they look to one direction
Short clip twice.
and it beats that way. And then if they go and they look to the other side, it beats in the other
Then when
direction.
she moves more central and to the left, you can definitely see that her nystagmus is now beating towards the left. Simply take your hand.
And then the
to
next
it,
thing I want to show you is
observe how I
the
first
next
take
step
away
of that,
my
which is
hand
something
from
So
called
super fast clarifier. So on that last one, then you're saying that
nystagmus.
unilateral is reassuring, the bilateral one is not, right?
Yes.
Okay.
And
Compare
we'll
that to
we'll
this
give
one.
an example, a
Which
really
looks
good
like
example of that. Here we go.
that's
I'm going to let you see it one more time.
The HINTS plus exam. This is indicative of a peripheral pattern of nystagmus. Compare that to this lady. When she looks to the right, she has small amplitude but abnormal horizontal nystagmus with a
He has a tumor.
to the right.
This one
When she
actually
looks
has
to the
a central
left,
cause.
You can see her nystagmus is now beating towards the left. So she has direction changing nystagmus or bi.
So I understand this is subtle. And in fact, I think even as emergency physicians, we have a very hard time with acute vestibular syndrome. And so I'm going to help you to understand the different areas where you can definitively say, I need to worry about this, and I don't, without having to get into the little details of nystagmus, the way in which I'm describing now. The nice thing about acute vestibular syndrome is that if you do have that inflammation of the ear, it always looks the same and with the exact same pattern. And that's why they have all of these different tests, because you're basically ruling out a stroke. And then the other thing that they had incorporated into the battery is covering one eye and looking if there's any shift. I'm going to show you that in a second.
Observe when I first uncover his right eye, the right eye moves medially and upward. And when the left eye is uncovered, it goes medially and downward. It gets a little less as we go along, but there's definitely some vertical skew deviation, which is a HINTS plus central.
So if this is not something that you see every day and you feel like you physically can't do this, the alternative is to look for a couple very prominent findings. Number one is ataxia. And that isn't just ataxia like I feel off balance, because a lot of people with benign positional vertigo and even with acute vestibular syndrome feel like they are off balance in it. But what ataxia is, especially like the worst of it, is when you put your arms together and have them close their eyes, they can't maintain focus. They just cannot, they keep moving in every direction because they cannot maintain balance whatsoever. Furthermore, when you do finger to nose, they cannot complete finger to nose. Any finding to suggest that is central until proven otherwise. And then that mixed with hearing loss is also like sudden onset hearing loss. Not somebody like me who has long-term hearing loss, but somebody who was hearing fine and now cannot hear out of the right ear suddenly. Both of those do bucket them to a higher category. So with that being said, let me go back to my PowerPoint here. Now, I just threw three very, very, very different but very important physical findings. I talked about posterior canal type, I talked about horizontal canal type, and I talked about acute vestibular neuritis. Those are the physical exams that we perform. And then there is the interpretation of those physical exam findings that is also important. So the posterior canal type in review is the Dix-Hallpike when you drop their head and you look for upbeat torsional nystagmus. The horizontal canal type is the beating left and right like this. And then the acute vestibular neuritis is they're sitting there at rest, they're dizzy, and their eyes are just beating on their own. And then you can actually look by performing this battery of tests called hints, which we can talk about, where you turn the head quickly and you look to see if the eyes move back to the same spot. You look to see if there's skew deviation. You learn to see if there's hearing loss. And that helps to tell you whether or not it's a stroke or not. So I'm going to move on to the next slide, but I do want to take a moment to address any questions about any of this.
There were a couple of questions. One, do the maneuvers cause emesis?
It depends if you bucket them incorrectly. And yes, they do. And you have to warn the patients that they're about to get sick.
Great. And then there's a
Oh,
question.
can I add something to that? It does cause emesis, and if they feel emesis because you get upbeat torsional nystagmus, I actually tell the patients, yay, I know you're vomiting, but that's an awesome sign, because that means that you're having something I can treat, and I can treat it right now. You can give them Zofran too preemptively. It does help.
And then there was a question, why does law enforcement use this test to determine DUI?
Yes.
Are you talking about pass pointing, or what?
No, they're talking about ataxia.
Yeah.
Yeah, and they're talking about finger to nose. It's because the cerebellum central alcohol intoxication is a central syndrome. It is an acute vestibular syndrome that is caused by alcohol intoxication that mimics that same part of your brain that isn't getting the oxygen it needs because of ischemia, is being duped into thinking that it's not supposed to work, which is why you get people who stumble. They don't have insight, which is similar to a stroke. You don't have insight that you have lost that function. And furthermore, you have the inability to do a finger to nose. Does that answer your question? That's a really good question.
That's all we have for now. Thanks.
I love it. Okay,
Me too.
so we talked about these tests, but how do you use them? And there's this diagram, and you look at the diagram and it says things like episodic, triggered, positional, continuous, and you're like, oh my gosh, what do I do? And it's easier to break down than that. So I made circles. So you take a history, you ask, are you dizzy now? And they say, no, it's only when I move. And you're like, okay, that buckets me into the episodic triggered category, which is awesome. Or you say to them, hey, are you dizzy? And they say, I'm dizzy at rest. I'm dizzy and I don't have to move. And I can't find, you don't have to trigger it at all. It's just sitting there. And that puts you into the acute continuous category. And then after that, you get to decide based on which one they have, which tests you do. So you never want to do one test on somebody else, because if you take somebody who has the continuous dizziness and you do a Dix-Hallpike, invariably they will vomit on you and you will get nothing from it, because then you won't be able to do any test to fix it, but all you did was make them vomit. So if you're going to make them vomit, it should be for a reason. And that's why if you do it in the episodic bucket, it's correct and it's appropriate. But if you do it in the incorrect bucket, all you're doing it is making them sick for no apparent reason. So you do your tests. And first test you do, and I lit that up here, this dizzy with movement, you do the Dix-Hallpike, and I add too many L's in the hall. And based on that, you decide whether or not it's positive or negative. If it's negative and they have atypical nystagmus, you got to get an MRI. But if it's positive and they have the typical type, then you do the Epley maneuver. And then similarly, when it's continuous, you do this HINTS test, which we were just talking about, where it's head impulse test and then skew deviation. And then you also want to make sure they don't have deafness. And that gives you a safe category. None of this you guys ever going to do. You're never going to decide in the field whether or not they have HINTS positive or negative. And that's what we'll talk about near the end. I'll talk about how to, I want you to have a general approach just for your own information. And so you have a nice, wonderful framework. And then we're going to talk to you about like what this really means to you and when you see your next patient. Is this helpful? Does anybody have any questions?
Super helpful. Nothing in the chat.
Love it. All right. So here we go. Let's go with some cases. I'm excited here. All right. This one is my own. I'm going to need some audience participation. Either you can say it or you can write it in the chat because I'm not looking at the chat. But this is my own patient. I'm going to turn it up here because I want you to hear all the details. Yep.
How about if I turn to this side?
Yeah. Tell me
Yes.
what you think's going on here.
Oh my God. Okay.
Okay. So, yeah, she's an elderly woman. She came in. She's not having dizziness at rest. It's only triggered when I do the Dix-Hallpike. What do you guys think's going on? I'm going to let you see it again. And please feel free to answer. I want this to be, this part is the fun part where I get to talk.
Yes.
Okay, let's see what.
Oh my God. Okay.
What do you think?
Posterior canal PPV on the left.
Yes. I wish I had chocolates. That would have taken it to the next level. They need to make virtual chocolates because, so yeah. So yes. So Philip Goldsmith, you get my virtual chocolates. I don't know where that's going to come from, but you've gotten my virtual chocolates.
I gave you a
Yes.
smiley face.
So this is perfect. This is a posterior canal BPPV. This is an interesting case, actually. I really enjoyed this case. She had come in and neurology just correctly diagnosed her with BPPV, but she didn't get better with the Epley. And so the problem was the little tiny piece of stone, the otolith, was stuck. And so what I did was I took her head and I shook it and I loosened it up. And the technique is called a head shake. And after I shook her head and I did it, it rolled right out and she felt 100% better. But she did vomit, just for your information. Right after I did this, she did vomit. Right after I did this, and I reassured her it was a good kind of vomit. All right, case one. Any other questions about posterior canal BPPV?
Nothing in the chat.
Love it. All right, let's go to case two here. All right, this is case two. So this is a young lady similarly coming in with dizziness, a little bit more like 2 weeks of dizziness. Yep. And she has this finding. And to go back, this was continuous, and she felt dizzy sitting there. And when we did our neuro exam, we did extraocular movements, and that's what we saw. What is the disease? Like, you don't have to tell me what the actual diagnosis is, but what's the physical exam finding that we're seeing? And is it point to peripheral or does it point to central?
So I definitely saw nystagmus on the left, looking to the left. I'm not sure, I'm not comfortable saying whether I saw it looking to the right.
Yes. Now, what's her right eye supposed to be doing that it's not doing?
following along.
It's not supposed to be. Yeah, exactly. So yeah, the right eye is supposed to go to the right side when you look right, and it should go to the left side when you look left. But when she looked left, it didn't follow. And you know why that is? Because she had a pontine hemorrhage that happened just the day before. Yep. So she had an acute hemorrhagic stroke. That's how she presented. We did the follow my finger. And then when you try to go to one direction, her right eye did not look to the left. And as a consequence, she had a pontine stroke. So that is a hard finding. Whenever you have a cranial nerve abnormality on your neuro exam, it trumps everything. That means that they're having something that needs to be assessed for central process. So nystagmus is only useful when you don't have a cranial nerve abnormality. When you do finger to nose and they're able to do it. When they sit up and they don't fall over. When you have them look both ways, they look up and down, left and right, and their eyeballs are moving the right direction. They don't have a facial droop. That's the point of this slide. If you have a positive NIH stroke scale, if you have a positive Cincinnati stroke scale, if you have a positive BFAST, that trumps everything. Now, the thing about the BFAST score does take into account dizziness so that we can get more dizzy patients in. In particular, the ones that you need to be most concerned about are the ones that also are off balance. I'm going to talk about specific things for you to keep in mind when we're going through stuff. All right, so that was case 2. I got more of these. All right.
She presented again. She didn't have any vision problems, right? She had
no, none at all. Vertigo. Yeah, none at all. She came in with vertigo. That's all she had. She said, I feel dizzy.
Yeah.
And then you you have her do this and she looks to the left. Wow. Yep. And this is typical for a pontine hemorrhage is that you only come in with isolated dizziness. And that's why dizziness has in the past been such a missed opportunity. And that's why when we are assessing the patient, we always err on the side of caution. But there are a few hard, fast rules that you can use to help guide you, which is what each of these cases are remembered for. So number 1 was a case of BPPV. This one was a case of a pontine stroke, and that's a hemorrhage. This one I thought was kind of interesting to add because it is a case that looks peripheral except for one thing. So when you do the whole thing, this is what they call a positive head impulse, which is a good thing when you have it, where your eyes take a little second to track, it takes a second to look back. And in addition to that, you have that little horizontal unilateral beating nystagmus. It's so minor, you could be fooled into thinking it's not really that prominent. So you could be fooled to think, okay, this is peripheral. I want to just give this guy some steroids, send this guy home. This guy has, and then I'm going to move on to where, here we go. This is the part that gets him into the central category. So you see how he had to look up there, and he looked down, and he looked up, and he looked down, and this guy had a stroke. This was a stroke. Yep. And so he ended up having a large stroke right in the territory right there. All right. I'm going to move on to the next case because I like this one a lot. Tell me what the finding is here, and does this point towards peripheral or central? If you saw this on your patient, the next patient you see, would you send them to the stroke center, or would you send them, or would you be reassured by this finding? Looking at the chat. Please feel free to speak up too. Especially if none of this is making sense, I'm happy to talk about it.
And how did this patient present?
Same as everyone else. She had constant vertigo that had been there for the last week and a half. And she came in because she was having a hard time walking. Every gaze, this is a patient. I'm just going to answer it for the sake. Another stroke. Yep, this one had similar to the last one, a large stroke. So anybody who has any type of nystagmus at rest other than unilateral horizontal nystagmus has a stroke, or has MS, or has something compressing the area of the cerebellum until proven otherwise. And in fact, sometimes I'll walk in the room and that's all I need to do. And I'm like, okay, patient needs an MRI, they're having a stroke. End of story. I don't need to see the rest of the exam. And truly, like and similar to that, I mean, I think I probably had like 10 of them over the course of the last few years that look just like that. All right, this one I actually love here. Let me show you this one. All right. Okay. This is from my colleague Sundar. So he has some horizontal nystagmus. Okay, great. You know, that's great. So then let's see what happens here, because, you know, we're doing more than just that. And I want somebody to tell me what finding he has. I'm going to let you see that one more time. Yeah, take a minute just to talk about that one. What do you guys think?
They just need a minute to warm up. They'll throw things in the chat.
Like I said, I don't mind either way.
Yeah, not much here. So it looked pretty ataxic.
Yeah, so the finger to nose is abnormal. Yep. So this is one of my favorite tests. Ah,
there you go.
There you go. Thank you. Thank you. I appreciate it. Yep. Finger to nose is abnormal. Yep. Gets an MRI. And guess what the MRI shows? Pow. Yep. Is a midbrain infarct. All right. Last but not least. This is left beating nystagmus. And then that's right beating nystagmus. Left beating nystagmus, and then right beating nystagmus. And this guy had a mass in his brain. He had a large cerebellar mass.
Wow.
He was grabbing. What did you say, bro?
I think it was in reference to the pass pointing. It looked like he was having a hard time identifying the finger and looked like he was grabbing the finger.
Oh, that's interesting.
In the ataxic example. No, in the prior ataxic example.
Oh, wait, hold on. I want to go back. This guy? Yes, absolutely. 100%. 100%, because that's one of your coping mechanisms. That's one of your accommodation mechanisms that you can use. In fact, do you know what the Parkinson's people can do? Because they have the ability to, so a Parkinson's person who has a baseline tremor can't walk because if they have this gross abnormality, if you put them on a bicycle, they can pedal bike normal. And it blows my mind. The reason why is because when they put their feet on a pedal, they have a feedback loop. And as a consequence, it allows them to use their balance in a way they can't do when they're walking and they have to find their steps. I thought that was very insightful.
That's so cool.
Okay, and then we talked about this a little bit. We talked about the different things you can do, like the Epley maneuver. You can give them vestibular suppressants like meclizine, but and also you can just have them change their diet. Like if they have ringing in their ears and Meniere's disease, you can change their diet. You can increase their calcium supplements because oftentimes this is vitamin D deficiency. And in fact, we did this huge study in India where we saw that there was a huge category of undiagnosed horizontal canal BPPV that was higher than anywhere else. And turns out that India has a very high population of vitamin D deficient patients. So like they have a very, very high number of vitamin D deficiency, which makes no sense being that it's so warm there. But yeah, so that is the treatment options. Now, this is the slide I wanted to talk to everyone about. And we're getting to the point where at the end of the presentation, it's perfect timing. If the patient is having nystagmus at rest, if they have a history of a stroke, if they have anything that's positive on their neuro exam or their stroke scale, or they have the inability to walk, I would err on the side of calling it a stroke. If they are having something where they are dizzy, we at Hopkins, and I'm sure that University of Maryland and other places have specialists who specialize in dizzy that actually come to the ED. And the patient comes in through triage and it's 7 to 5:30 p.m. The teledizzy group will come down and Justin or one of the nurses will actually capture the images and then send it to a neurotologist. And the neurotologist will say, this is consistent with BPPV, do this, have them follow up at the clinic tomorrow. Or they'll say, uh-oh, this is concerning for something central. We'd like you to consult neurology. And so I think that that is a really cool, awesome futuristic thing where we'll be able to like do that so that all emergency departments are empowered to be able to make a better diagnosis with dizzy patients. And plus, they won't have to spend all the time learning about hints and learning about this and that. They'll know enough about it to be able to bucket them correctly, but they won't put them in a situation where they are committing a treacherous error, like discharging somebody and just giving them meclizine, saying, oh, it's probably benign, and it turns out to be a stroke. Or worse, doing unnecessary tests, MRIs and CAT scans and all of this and admissions, and really they had something you could just do a quick 5-minute thing and fix them. In addition, as we said earlier, this is a high risk, low frequency disease that we're trying to detect. And like we said earlier, 33 or 35% of them are not vestibular, they're not in the brain. They're URIs, they're heart attacks, they're pulmonary embolisms. So if they're having any other symptoms or they have a history of heart disease and they're coming in with dizziness, that is something to also consider. Does this patient need a cath, a cardiac cath? Does this patient need to go to a center where that can be done emergently? So that is pre-hospital considerations. And then there is an article specifically that looked at this, at the outcomes, and I have the references at the end. And what they found in the pre-hospital setting was that 3 factors were associated with reduced risk. Number 1, if the dizziness was rotary type, which we talked about because it points towards benign positional vertigo. If the dizziness had sudden onset, because once again, it points towards a little piece of a fleck getting lost. And then third, interestingly enough, if the patient had a fever, and the reason why that is because it points towards that 33% who had URIs and away from stroke. Although you have to be careful because sometimes central basilar artery strokes cause fever. So it's something that I would take with a grain of salt. Furthermore, 5 factors are associated with increased risk. And these are things that I think everyone should consider. If you have a thunderclap headache, which means that it's like Zeus launches a thunderbolt, hits you in the head. That's why it's called thunderclap. That is a problem. That needs to be assessed immediately with a CAT scan to make sure there's not a subarachnoid hemorrhage. If you have a history of trauma, that was associated with increased risk. if there's any type of nausea or vomiting, but once again, that overlaps with BPPV. But because if you're with BPPV, if you have it at rest, you're not having symptoms, that helps you with that. And then lastly, any anticoagulants or increased blood pressure, because increased blood pressure makes you at higher risk for stroke, both the hemorrhagic and the ischemic type. So that is my summary. And I'd like to spend the last 7 minutes, if anyone has any questions or they want to talk about anything dizziness, happy to talk about it. I have my email too. If anybody has any desire that they would like to talk about it at in a more private setting and not in front of everybody, please send me an email. Tell me what you think. Tell me if there's anything that was confusing and you need help to understand. I'm happy to explain any of that.
Rodney, you're such a great educator. Thank you so much. What a useful framework to put on this. Yeah, I know you say infrequent. Doesn't feel very infrequent in pre-hospital setting in my experience. So yes, to put some framework around it and some confidence about what direction we're heading. Super helpful. Any questions you guys want to come off mute or share in the chat?
My pleasure.
You get a copy of the beginning of this presentation with those charts?
So I'll be posting the recording version. If you look at the EMS Academy announcement, you can see where the, or Ashley can put the link, hopefully. I can put the link in the chat, where you can see the recorded version of this. Is that helpful?
Yes, definitely. Thank you.
You're
Is there a
welcome.
way I can, you think I could just make a quick thing and just put it, is there a way to put it in the chat? Just I can send my slides to anybody too.
I mean,
they'd
you
like.
can drag your slides into the chat box. It might
Yeah,
take,
let me see if I do a quick print. Maybe I can make a quick PDF while we're talking here.
but I think the video actually is quite good.
Yeah.
Oh, I love it.
If we can download that, that'd be fantastic.
So you can't download it, but it's in the public domain.
No, I meant the slides.
Yeah, I got it.
Let's see, slides. Let's see how quickly I can do this. Maybe I can do it in the next 3 minutes. If not, I'll put it up somewhere. All of this is my own work. All of this is, yeah, all the images here are images that I have used in my prior publications. So all of this can be shared.
I
And
put a
I'm
link
happy-
in the chat for the videos. So Ashley will put this video in the that link within the next week or so, I would say.
I love it.
And then we'll see if Rodney can upload his slides.
Let's see, desktop.
But I am going to end the recording, and just before I do end, I certainly need to thank you so much for being with us, and thank you for sharing, and thanks for all that you're doing. We appreciate you.
Let's see, how do you upload with this thing?